Welcome everyone to this month's BJJ podcast. I am Andrew Duckworth and a warm welcome from your team here at the Bone and Joint Journal. So far this year, our podcasts have accompanied an original paper or review article we have published in the journal. We have covered a range of topics, as many of you know, including the management of open fractures, the role of denosumab in giant cell tumours, and recently a really excellent discussion on the role of cell therapies in orthopedic surgery. We do hope these podcasts are improving the accessibility and visibility of the studies we publish here at the journal, for both you as our readers, as well as for our many authors. As some of you may know, for the months of June and July, we are doing an extra podcast to accompany our supplements from the American Hip and Knee Society closed meetings. So over the next 15 or 20 minutes or so, we'll be discussing the June supplements of the BJJ that includes 17 papers from the American Hip Society closed meeting in 2018. We hope to give you a brief overview of the Hip Society and who the members are, as well as discussing how this collaboration came about and how we hope this will benefit you as our listeners and readers. We also hope to give you a behind-the-scenes insight into how the studies within the supplement have been chosen, as well as some brief description and discussion on a few select papers. So firstly, I have the pleasure of being joined by our Editor-in-Chief here at the BJJ, Professor Haddad. Welcome, Prof, and thank you so much for joining us.
Thank you, Andrew. It's great to be here.
Prof and I are delighted to be joined by the guest editor for the Hip Supplement, Mathias Bostrom, who is the Chief of Hip Surgery at the Hospital for Special Surgery in New York. Welcome, Dr. Bostrom, and thank you again so much for taking the time to join us today.
It's great being here. Appreciate the time.
So, Dr. Bostrom, if I could start with yourself, just for our listeners and readers, just a brief overview of what the Hip Society is and what role it sort of plays in the hip community.
The Hip Society is a small group of distinguished hip surgeons from the United States and internationally. It is a relatively closed group of individuals. There's less than 100 members, and it is by invitation only. They have a mission of advancing the care of hip disease and taking care of patients who have various hip disorders, and it ranges from the adolescent hip to the very geriatric hip. It really encompasses all sorts of hip disorders and trying to improve that. The primary mission of the organization is obviously to do that, but through primarily education and research. And it's been around for about 50 years. It was started by a number of Americans here in the United States, but it has an international membership as well.
And Dr. Bostrom, you obviously have the closed meeting, which the papers come from. But you have an open meeting in the academy as well. Is that right? Just describe those two.
So the group actually traditionally has had two meetings: a closed meeting just for the members, which is incredibly stimulating because the group knows each other well and really can get to the meat of the topics without a lot of the fluff. And then the other main meeting that I think the public is aware of is at Specialty Day at the AAOS meeting. There they cover a wide range of very timely topics within hip surgery. I think the important part is it's not exclusively arthroplasty, but other hip disorders as well. So that includes trauma as well as developmental disorders.
Okay, so obviously a broad range. That's really helpful, Dr. Bostrom, for sort of an overview for the listeners about what the Hip Society does. So, Prof, if I could come to you, obviously we'll discuss it again next month in the Knee Society supplement, but can you give us an insight into how our collaboration with the Hip Society has come about?
Indeed. In reality, as you know, we at BJJ always look to have the broadest reach to educate as far afield as we can, and also to get the best material for the Bone and Joint Journal from the best authors, from the thought leaders, and those who are really changing the nature of what we do clinically and improving the care of our patients. So we had a win-win here in that a couple of years ago, it became clear that the Hip Society and indeed the Knee Society were keen to relook at who published these very important papers from their proceedings. And we felt that this was an ideal partnership for the Bone and Joint Journal. It would deliver for us collaboration with people like Dr. Bostrom and the other thought leaders in North America to get their work and their papers into the Bone and Joint Journal, to get them engaged with the Bone and Joint Journal family, reviewing papers for us, and indeed for us to spread their work and their message worldwide, where the BJJ has a great reach. So when that opportunity came about, we thought this would be an ideal partnership for us to put in place. So we set forth the communications and went through the process, and we were successful. And it's really been a privilege to work with Dr. Bostrom for the last few months to put together this particular supplement from the closed meeting that took place last year, the very good closed meeting that took place last year. Yeah. I think this is a huge opportunity to profile some fantastic work across the breadth of hip surgery for our readers.
No, I totally agree, Prof. And I think obviously when we'll come on to discuss a few of the papers, I think the quality is without doubt. But just for, I suppose, for the listeners, just before we move on to some of those individual papers, could you just give a brief insight about how the papers were chosen and peer reviewed prior to acceptance for publication in the supplement?
Absolutely. As you know, we pride ourselves on a very rigorous process of peer review at the Bone and Joint Journal. And we also have this unique process where the papers then go through primary editing by orthopedic surgeons to get them to a point where they are really very readable, very crisp, very clear, probably the best presented material you'll find out there. So these papers really have been through the mill because they're initially presented by members of the Hip Society. They have to be members of the Hip Society to get into the closed meeting, and they're selected by Mathias Bostrom and his team to be presented at that meeting. Out of those papers presented, there was a call for papers to be submitted to peer review at the Bone and Joint Journal, and these were sent in by December 1, at which point all these papers went out for peer review. And this was a fairly complex peer review in that we ensured they were reviewed both by BJJ regular reviewers who were used to our processes, but we also introduced Hip Society and North American reviewers to this process so that we got their context on these papers as well. So each paper had multiple reviewers and then came through a process that involved Dr. Bostrom as guest editor. So really, we hope this has really selected some key papers that deliver very important messages and that will influence practice in hip surgery moving forward worldwide.
Dr. Bostrom, anything you would add to that at all?
Yeah, I was going to say that there's no question that this starts out with well over 150 papers that are presented at the closed meeting, and is basically come down to a dozen and a half really top quality papers. So it's sort of the best of the best, and this is a group of individuals, and the concept of thought leaders is really the most important part here. This group of thought leaders presents their best material, and then that best material is what's being published in the BJJ. So it is a sort of the best of the best in terms of content, and timely also. I think themes within medicine change continuously, and certainly within hip surgery, the themes have continued to change.
Yeah, that's right. No, absolutely. It's obviously very robust. It's almost like a two-tier sort of review process there. And like you say, it's almost less than 10% of what's published at a really high-end meeting. So it really is high quality. So, I mean, given that, so we should probably move on to the supplement itself, Dr. Bostrom. So obviously there's a range of topics there that are discussed throughout hip surgery, as you've already described. But what do you feel are sort of the core or topical themes from the papers over the past year that were presented in the supplement?
Well, I think the timely topics remain. Surgical approaches has been obviously a very hot topic for a while. We continue to follow what's happening in the adolescent hip surgery realm as well. In the United States, cost effectiveness and perioperative care, pain management are very, very topical and really important topics in terms of how we manage patients. The usual topics of bearings and outcomes and infection and revisions are also themes. So it's a broad range of topics. Some are sort of time-honored. Revision hip surgeries remains a topic. Infections, unfortunately, are not going away, but I think there's some really interesting ideas out there in the infection world as well. And then things that may be a little bit, I certainly see the excitement about different surgical approaches is coming to a close, and and new things are coming up instead. So it's a broad range of hip surgery topics, but also perioperative management, which is a big deal in the United States. Outpatient surgery for these disorders is a big deal. Not so much in Europe, and certainly in the United States. And it's pushing the envelope on how quickly we can get people moving after hip surgery.
Yeah, no, absolutely. And that's a really good summary of them, Dr. Bostrom. And I think as well, not just in hip surgery, it seems two of the core topics that seem to run through a lot of the meetings now is, as you say, about sort of pain relief and opiate use in particular, and also just, getting our patients perioperatively optimized so we can get them through the system as quickly as possible. But sort of moving on to the two, there was obviously two prize or award papers in the supplement. The first is sort of a large study of over 6,000 patients from a single center that looked at the impact of surgical approach, as you said, on the joint infection rates. And the second was from the Mayo Clinic, looking again at a large series of patients having hip and knee arthroplasty, and the role of, quite interesting about the role of allergy testing and comparing infection rates when you use or don't use a cephalosporin. Do you mind just giving our listeners just a brief overview of the two papers?
Sure. I'll start with the surgical approaches paper, and this was done from a single center here in the United States, and they looked at a several-year period of over 6,000 patients, and they looked at whether they did a direct anterior or what they refer to as a non-direct anterior. That includes obviously anterior lateral as well as posterior, and over this relatively contemporary period of time, two things they found. One, certainly the rate of infection within a direct anterior approach was 2.5 times that of the non-direct anterior approach. A little bit surprising, I think, especially if you consult Dr. Google in terms of what kind of approach you should have. The other was that they also instituted some pretty aggressive protocols to decrease their PGI rate, which was rather on the high rate, certainly relative to other institutions. And they found during this relatively short period of time of 3 or 4 years that they basically halved their infection rate. And so two major take-home messages from this paper was, one, it looks like approach does matter in terms of infection rate, and two, if you institute appropriate protocols to decrease the rate, you can actually have a pretty profound effect in terms of diminishing the risk of infection. And to the point where at the tail end of the study, although the direct anterior approaches still had a higher infection rate, it was a much more reasonable rate at that point. The other paper from the Mayo looked at the use of allergy testing, and they obviously have huge numbers of patients, but they've over the years have had a very aggressive approach to patients who come in and state they have allergies to various antibiotics. And so they referred patients to their allergist. A fairly large number, almost a quarter of their patients ended up seeing the allergist. Granted, that can be done at the Mayo because it's the Mayo and the way the system works. But the interesting finding with them is that if you use a broader-based antibiotics like cefazolin, which we do here in North America, the infection-free survivorship was much, much higher. And so the take-home message here is, if someone states that they're allergic to penicillin, they probably aren't, first of all, and if you can give them cefazolin, a broader spectrum of antibiotics, their chance of infection is lower. And so if you don't know if they're allergic or not, send them to an allergist. Chances are they're not going to be allergic, and then you can give the broader-based antibiotics, and they're going to have a better survivorship in terms of infection. I think important take-home messages in this one. And the risk of infection was pretty significant if they were able to take cefazolin. It's about 33% less, and
it's quite big, isn't it? Yeah.
That's a big deal for even a small institution. If you can cut your infection rate by a third, that's not insignificant, and societally a huge deal.
Absolutely, and as you say, we often experience it here, is people are not sure about their allergy, are they? And so it's difficult to know. And so this is an interesting paper that sort of stimulates discussion about that. Is there anything you'd add to that, Prof, at all about those two papers?
I think the second paper in particular is going to be practice changing for many people and will lead people to reflect on allergy histories more carefully and to rethink. We really need to think. We've gone around the houses, certainly in the UK, with prophylaxis. So I think there's a lot to learn from that.
No, I totally agree. Prof, just to come back to yourself, I was wondering if we could, obviously another paper in the supplement we could just thought we'd briefly discuss was your paper about the outcomes of repeat two-stage exchange hip arthroplasty for periprosthetic joint infection. I mean, obviously, potentially an increasingly topical area, I imagine. I just wonder if you could just briefly give us an overview of the paper and what made you look at it in particular.
No, absolutely. As you probably know, about just over 20 years ago, I came back from Vancouver and was very fortunate to work with Jeff Ridgway and set up one of the first MDTs looking at infection. And so we started developing our algorithms and treatments, and we've almost seen a full circle in that initially we were getting referred the infections primarily and dealing with them as a sort of specialist infection center. And then more and more revisions were being undertaken for infections elsewhere, and we were seeing the more complex failures come our way. And it rapidly became clear to me that people were coming to us having had multiple interventions, having had very powerful antibiotics, and really being in some difficulty and tough to salvage. So we wanted really to take a more recent snapshot of what those cases looked like where two-stage revision had failed, just to really sort of back up what was a simple perception that it really wasn't benign when that happened. It was a difficult problem to get out of. And so it's a really simple look back at those cases that had a failed two-stage exchange to see what happened to them. And the outcomes were pretty predictable. This is a high morbidity, high mortality disease when there's a periprosthetic infection. Quite a few of those patients died. And our data looks like the data from the Mayo Clinic and other big infection centers, in that there is a high failure to control the infection rate. Although we were lucky to control the infection in over 50%, there was more than a third of the patients that either required repeated surgery, antibiotic suppression, or ablative surgery. So this is a really complex group. We need to really understand their prognosis and be able to communicate that with them. And I think it will also feed back into that big discussion that we're starting to have about what the right intervention is for an infected arthroplasty in the first place, rather than escalating up the ladder very quickly. Debridement, implant retention, single stage revision, other procedures may have a role before we escalate up to this level. And we also, as Mathias said earlier, need to look at other forms of both prevention and management of infection. It is still a devastating disease for our patients.
Absolutely. Anything you would add to that, Dr. Bostrom, at all?
Yeah, I think Professor Haddad's work is really incredibly important because it highlights how really truly devastating this is. And even though in the gold standard in the United States is this two-stage exchange arthroplasty, it may not be the right answer for everyone. And I think we have to start thinking outside of that traditional paradigm, especially here in the United States. Elsewhere, I think in the world, they're doing that already, as being done in England by Dr. Dodd and his group. So it's I think it's a topic that's not going to go away in the next 5, 10, probably unfortunately 20 years. But I think we have to think about it differently.
No, I totally agree. And I think that I wish we had a bit more time to discuss it, but I think that's running out of time there. But thank you so much to you both for joining us for our podcast today, and congratulations on a really excellent supplement. Thank you very much, Dr. Bostrom, for joining us all the way from America. It's very good of you.
Yeah, my pleasure.
Thank you, Andrew.
Thanks very much. Thank you, Prof. That's great. So to our listeners, we do hope you have enjoyed joining us today, and we encourage you to share any of your thoughts or comments through Twitter, Facebook, and the like, and feel free to post or tweet about anything we've discussed here today or any of our previous podcasts. And thanks again for listening.